So good afternoon, Dr. Swaminathan and Dr. Roy. On behalf of GSK and the Hindu, I welcome you to this webinar, which is Adult Immunization, Healthy Aging Matters. And just as we were discussing a little before the webinar began, it is a matter of great importance that we know and we learn a lot more about it. Somehow adult immunization seems to have slipped through the cracks. But before we start, a brief introduction about the two doctors who are with us today. For those of you who have signed in, the two very eminent doctors who are going to be sharing their words of advice and the information and why they think adult immunization is something that we should all sit up and take note of. You know, immunization doesn't stop with children or pregnant mothers, as Dr. Roy was mentioning just a few minutes before we began. So Dr. Subramanian Swaminathan is a consultant, Infectious Diseases Global Hospital, Chennai. Dr. Sitesh Roy is from Mumbai. He's a senior consultant, allergist, immunologist, and asthma specialist from the Roy Health Solutions Clinics in Mumbai. And he looks after both the kids and the grown-ups. So it'll be very interesting to see to hear him on the importance of immunization for both, particularly the elderly. As you're aware that the last week of April is World Immunization Week, and this time the theme is long life for all, I think, if I'm not mistaken. Yeah, it's long life for all. And without much ado, we can begin the session. Dr. Subramaniam, this year the theme for the World Immunization Week is long life for all. So, you know, as themes go, we are all very fond of having themes and slogans and things like that. But obviously, this has special significance. And as a doctor, what do you think about it? What are your...
Well, apart from sanitation, the biggest advancement in public health has been vaccination. In the last 200 years, vaccines have contributed to a lot of human welfare. And in fact, when you talk about eradication of diseases, smallpox being a swan song, I think we could not have done that. Not just I think, we know that we could not have done that without effective vaccination. So obviously, this is one of the greatest things that we have in our armamentarium to improve public health. Obviously, it is moved from a situation where we talked about vaccination for children, because childhood deaths were a bane about 200 years ago. But today, survival beyond childhood is fairly routine. And therefore, we need to start looking at how vaccines can improve life and livelihood for all age groups. And as we have an aging population, and as we have more vulnerable population, I think that the concept of having vaccination, which is appropriate for all age groups, is something that can help us live a more productive and a healthy life. And I think that's exactly what everybody wants.
That's true. That is, I mean, you know, it is to focus on the quality of life as well. And you, as you rightly said, you know, infant mortality was up front and foremost in everyone's minds, and they were trying to bring the numbers down and so on and so forth. But now that we have moved on a bit, there's still a lot to be done, but we have moved on a bit. It is important to have a quality of life, which some of the vaccines will assure us. Dr. Roy, if you could just explain to us what is it that a vaccine does to the lay person? For most of us, it's just that, you know, we go to the clinic, get a jab and come back. But, you know, how significant is it? How exactly does a vaccine ensure good health for us?
So when vaccines were first designed more than 200 years ago now, especially from the use of cowpox pustules to vaccinate against smallpox, where it all began, with Edward Jenner and a few people before him. And very interestingly, if you look at the history, this was actually being done in India over 1,000 years ago and has been mentioned in Charaka Samhita and Sushruta Samhita as a form of vaccination. So it's very interesting that the origin was in India and then got carried to the Europe and get started. But what vaccination does is any infectious disease, when we have to protect someone against it, we can either take the entire virus or bacteria or a portion of it and convert it into something that is either killed or inactivated and inject it into the child or the adult, so that now the body can develop both antibodies, which is called humoral immunity, and something called cellular immunity. And with what is called the primary immunization, followed by what is called booster doses, we are able to sustain a long-term effect of this vaccine, so that when the body sees the actual infectious virus or bacteria again, it already has what you call sleeper cells in place, both of the T cell, which is the cellular immunity, and the B cells, which is the humoral immunity and makes the antibodies. So they get rapidly activated and can neutralize the virus or bacteria very quickly. And I think that that's the entire concept of immunization, that you take care of the infection very rapidly and efficiently, and especially prepare it for the ones that you're most commonly going to get exposed to, whether it's a child or an adult.
So basically, what the vaccine does is it sets up a kind of a defense mechanism in the body
to
fight the infections as much as they can. Okay. So, Dr. Swaminathan, if you had to look back in history, what would you say was the contribution of vaccinations to human life, to humanity?
Well, over time, it's actually undergone certain changes, and that is inevitable in science as well. It's expanded its horizons and its applications. Let's look at it. Dr. Sitesh Roy beautifully put it as to how the history of vaccination started. And we know smallpox, and we know how it has worked against polio. But it's also driven down so many other childhood diseases, be it measles, mumps, rubella, so many diarrheal diseases, pneumonia, so many things we have made a positive impact on. But beyond that, there is now newer applications of the vaccine that are coming up. Beyond, of course, safeguarding the elderly population, those who are vulnerable against diseases, there is now vaccines which are available for other indications. For example, prevention of cervical cancer, which is a major reason for morbidity and death in younger women. And it's a horrible disease. So we have very, very effective vaccines against some of those things. We have a vaccine against the most common reason for liver cancer, which is hepatitis B. We now have applications for the BCG vaccine, which involves treatment of bladder cancer. We have applications of vaccines today, which we never even dreamed possible, maybe just about 40, 50 years ago. So I would say that the technology and the scope of utilization of vaccines is exploding right now. And it's actually very interesting times to be involved in public health and in vaccination today than it has ever been. But also frustrating that there is a distinct lack of awareness which is paralleling that.
That's true. There seems to be a lack of awareness about all these vaccines. So,
Pankaj,
yes,
I would just like to add one point
to
what Dr. Subramanian said.
Yes.
If you look at the pediatric age group alone to know what contribution vaccines have done for children, before the routine vaccination schedules for children were around, 30% of children, mark my words, 3 out of 10 kids died before age 5 due to vaccine preventable diseases. That's a very high number to lose kids below the age of 5. And today that same number ranges at less than 1 in 100, even in some of the most underdeveloped spaces where there may be limited vaccination. So I think, as he has mentioned, just with diarrheal diseases, pneumonias, and the common infections that kids have, the chance of what you could call chance of survival, and hence the chance of a good quality of life later on as the vaccinations continue, and we'll speak about that for adults, the contribution of vaccination to humanity is huge. Smallpox used to kill 5 million people every year up until 1967. And in 1979, it was eradicated from the world just because of a good vaccine.
That's true. Yeah, it is remarkable. It is remarkable. And the statistics you say about, from 3 out of 10 children, if it's come down to 1 in 100, that's a huge step, especially in, developing countries and in underprivileged bits of the world, underprivileged areas of the world. since considerable amount of work and awareness has been generated for vaccines for children, Dr. Sitesh, what do you think? What do you think are the principal vaccines that the older person should get? And when I say older, I don't know how you classify it. Do children, what is the age group where you consider them as
children? So 18 years of age is where we consider the pediatric age group to end, at least internationally. Some people in India will consider it to end at 16, but 18 internationally is recognized as where childhood or adolescent immunization ends and adult immunization begins. So between 18 to, let's say, 40 or 49, there is a group that's divided, and then there is a group above 50. And each of these groups have unique requirements. So when we take the 18 and above group up till 40s, vaccinations that have come up, including for tetanus, diphtheria, and pertussis, which is pertussis is whooping cough. Tetanus, we all know, is called lockjaw. And diphtheria is again a respiratory infection. And this vaccine is given in childhood as a course with boosters, but it tends to wane in 10 to 12 years on an average. So even in America, it is considered to be one of the optional vaccines that is given to students who are coming into dormitories, along with something called a meningococcal vaccine, a vaccine for meningitis, which is very, very important because meningitis can take the lives of very young adults, as I would say, especially living in dorm or hostel kind of circumstances. And when you take that a step forward and you look at it, influenza vaccination remains very important internationally in many countries. Everyone above the age of 18 is recommended to get it. We do give it to children in India, and in India, we largely give it to high-risk populations. But that's also a very important vaccination. And when you come into the higher age groups, and I think the HPV vaccine that was mentioned by Dr. Subramanian earlier is very important for sexually active girls and women between the ages of 16 and 45 or 40, depending on where you look at the criteria. So I think that is again a important vaccine that is considered in those age groups. Beyond that, when we look at the above 50 group, again, the tetanus, diphtheria, pertussis, which is called a Tdap vaccine, is very important. Influenza vaccination, flu vaccination becomes important. And also a very important one called a Herpes Zoster vaccine, also called the shingles vaccine. And this vaccination, again, people have really underestimated, and we see a lot of cases of shingles, and there's something called post-herpetic neuralgia, which is severe pain that a person suffers from long after the herpes infection has resolved. And this can really compromise a person's quality of life immensely. Means there have been case reports of people being driven to suicide because of the degree of pain they were suffering. So sometimes it's these things that are very, very important. When you combine all these and you look at adults who are at high risk, then in high-risk adults, especially in people with COPD, asthma, you're looking at other vaccinations also. So list is quite long. I'm listing just a few of them, but there are a lot of vaccines that are available and required for people above the age of 18, if we look at adult immunization.
Dr. Swaminathan, what would you say about it? Would you like to, do you have a kind of top 5 vaccines those above 18 must absolutely have, with others coming in,
Certainly. No, I think he's mentioned it very beautifully.
Yes.
So I'll put another spin on it. So, pregnant women, everybody gets a tetanus toxoid. Although I doubt if anybody knows why we give the tetanus toxoid to pregnant women. I mean, I ask medical students this, I ask people who come for my lectures this, and I rarely get the right answer. The answer was, in those days, it was farm implements which was used to cut the cord, and babies died of tetanus. It was more for the baby, not for the mother. It was for the baby to protect them against tetanus. And the best way to protect the baby is vaccinate the mother so that the baby is safe. That's why we give the tetanus vaccine. Point is, today they've expanded it. And today when we say the pregnant women should get the influenza vaccine, there's a lot of people who feel uncomfortable saying, oh my God, is it safe? It's not for her. Yes, it does help her, but it's primarily for the baby, because studies have shown, at least quite a few studies have shown, that when the pregnant mother gets the flu vaccine, it reduces risk of all-cause lung infections, which are a serious killer in babies. So it reduces bad things in the baby. So the way to protect the baby is to protect the mother. We know that, and that's why we vaccinate. So I think there are larger effects than what we initially perceive. Right? When we vaccinate the children with the pneumococcal vaccine, what they noticed was pneumococcus disease in adults also came down. There are indirect benefits. There are benefits which may not be obvious to the eye, but if you look harder, you will see that these things are interconnected. So none of this happens in isolation. None of this is a silo. They are all interconnected. There are both individual benefits and public health benefits. We talk about herd immunity. That's a public health benefit. These are other benefits which we are not even something which we think of on a conscious basis. So I think it's important for people to understand that it's just not themselves alone. They are actually doing a lot of positive things for the rest of their family as well. And another example would be what we call ring vaccination. I have a lot of transplant recipients, both pediatric and adult. In those patients, it's very difficult to protect them. So the way we do that is vaccinate everybody around them, and all our healthcare providers also get all the vaccines that are recommended, so that that person in the center is safe, because there is a protective ring around them of immune people. So there are many, many different approaches like that, which are very, very beautiful to understand. But ultimately, the idea is to ensure safety, especially of the most vulnerable. And that's where the concept of vaccination should be looked at every point of time. It's not just about you, it's about your family and your community.
Community, that is right. I wonder why there has been this, this lacuna in awareness about vaccines for the grown-ups, so to speak, because I don't know. I mean, it is for the community at large. It is for the family. It is, it has large-reaching, far-reaching positive impact and consequences. And somehow we seem to have missed the boat somewhere. The other thing which I wanted to ask Dr. Subramanian was, I was asked to ask you was about the influenza vaccine. Now, for a lot of us, we just dismiss it as, oh, it's just the flu, But how important or how crucial do you think the influenza vaccine is? And do we take it every year, or how does it work?
So the problem is we work by binary logic. All of us think as a yes or a no. But in life, nothing is a yes or a no. A lot of things are a maybe. And here's the problem. Why am I worried about the influenza? Okay, so it's just a running nose and a cold. It's not. Okay, so what they noticed was, when they started doing influenza, they noticed that pneumococcal pneumonia deaths came down. That doesn't make sense. You give the flu vaccine and bring down pneumococcal pneumonia deaths? How does it make sense? Because the number one reason for pneumococcal pneumonia is a secondary infection after a flu infection. And vice versa. If you give pneumococcal pneumonia vaccine, you reduce influenza deaths. Because severe influenza, one of the major killers there is pneumococcus. So these are interconnected. That's one example. The second thing is a very beautiful article which came out in one of the leading journals called NEJ. What they showed was, if you develop influenza A or influenza B, in the next 1 to 2 weeks, the risk of heart attack and heart failure goes up about 10 times. Right? So I tell my cardiologist, you do so many things for prevention of a heart attack. You give them aspirin, you give them cholesterol agent, you give them sugar reducing medicines, you give them blood pressure reducing medicines, all that is good. But the cheapest of that is the flu vaccine. And the flu vaccine, basically on retrospective studies, is shown to be as effective as an aspirin pill in reducing the risk of heart attack. So I would ask my patients this, if you don't want to have a heart attack, and if you're at risk for it, just like you do all of these things, take the flu vaccine once a year, and it's very easy. It's just one shot and you're done for the year. The problem is influenza is a smart virus. It's a little smarter than all of us put together. It keeps moving. It's smart. It keeps moving. Yeah, come on. It's got to outsmart us. See, otherwise it'll become like smallpox, right? Where is smallpox? Who knows smallpox, right? So it's a little smarter than us. So the point is, it is able to outrun us. So we need to keep playing catch up. But my point is this: if you think the cost of it was high, even if you had one mild respiratory infection and you have to go see a doctor in the outpatient, get a consultation, get medicines, get some tests, it is still working out cheaper. And based on the number of heart attacks that you could prevent, heart failures that you could prevent, and things like that, it works out a heck of a lot of cheap. How do we know that? How do you know it's true? In Canada, the government actually keeps data on this. 2006 data, I'm quoting that. They look at how much money is put into the flu vaccine campaign, meaning acquisition costs, distribution costs, administration costs, record keeping costs, everything. And they look at healthcare saving, how much healthcare expenses come down. It's very simple. For every dollar they put into the flu vaccine campaign, the system saves $45.
Oh my goodness.
It's like saying, I give 1 rupee to you and you give me back 45 rupees. There is no healthcare investment. There is no intervention with such a high return on investment. It doesn't matter whether you're a cardiologist or a gastroenterologist or a neurosurgeon. There is no intervention which is this powerful. And this is 65 and adults, or over adults. The pneumococcal vaccine, the return is 1 in 8. $1 in, $8 out. So it's a no-brainer. Economically, does it make sense? Yeah. From the medical point of view, does it make sense? Yeah. But I will make one other comment if you permit me. You talked about why there is a reluctance in the general public. I'm sorry, I blame the medical community for that. Studies from the US have shown that the number one predictor of people getting the vaccine is the healthcare provider recommending it. For influenza vaccine, if the provider did, this is a study again, I'm quoting, if the provider did not recommend the flu vaccine during the visit due to any number of reasons, the uptake was about 11%. On the other hand, if the provider had recommended it, it goes up to an 89%.
Oh my goodness.
So our system is unfortunately very inefficient. In the West, if you get admitted today for any number of reasons, whether it's heart failure or pneumonia, whatever it is, they have an order set at the end of which automatically you have to ask, have you had your flu vaccine? Have you had your pneumonia vaccine? And if it is not done, at the time of discharge, it's offered to the patient. And it is captured as a quality marker, right? So I wish people like NABH and accreditation system start looking at that. It would be nice, because if you start doing things like that, it's only when you start measuring things that you start improving upon it. Right now, we are not measuring it. We are not improving upon it. It's not that doctors don't care. It's just that there are so many competing interests for a doctor's time that they may not necessarily think of this at that point. And this is across the board for every group of doctors except pediatricians.
Pankaja, I would like to add, I think
Yes,
Dr.
please.
Subramanian has made very good points. I'll just
Yes.
like to add two things.
Please do, please.
Influenza is what COVID-19 has been for us in the last 2 years. The last 3 major pandemics in the world were driven by influenza. We've all heard of the Spanish flu, which didn't actually begin in Spain, but it killed 1.7 crore Indians and 5 crore people around the world. We are now worried about 50 lakh deaths due to COVID-19 in today's day and age. We are talking about a significantly higher number dying just from influenza. And there is data again from the US that on an average, 1,500 to 2,000 deaths due to influenza in a well-developed country with a vaccination protocol in place for all live human beings above the age of 6 months to receive a vaccine every year. And they still have those many deaths, and many of those people are healthy adults. So just like COVID took lives of perfectly healthy human beings, influenza can take a perfectly healthy human being all the way to the ICU with a cytokine storm and take their life. So it is, and as Dr. Subramanian said, you know, besides the groups he mentioned, I treat a lot of patients, children and adults with asthma from around the world and all over India. In asthma and COPD, again, a simple influenza infection can drive a person to a severe flare-up of their underlying asthma or COPD and land them in the ICU on a ventilator, just a simple influenza. So we routinely offer it to all our patients with any respiratory diseases. And as he mentioned, cardiovascular is a very good example. And anyone with any chronic illness, someone who's been through a transplant, someone who's been on immunosuppressive drugs, someone who's been through any kind of serious illness where they're, or cancer, recovering from cancer, getting cancer treatment, chemotherapy, all of these groups are kind of immunosuppressed, where a simple cold, cough, and fever, which you and I may get over very easily, could be life-threatening for them. So, and as Dr. Subramani rightly mentioned, when you talk about immunization, in such groups, doing for the whole family becomes relevant. I vaccinate entire families of kids and adults who has asthma, because I know that if no one is in the house, no one else will get it amongst them.
That's right. That's right. Yeah, well, I'm not going to dismiss it as, oh, it's just a flu, henceforth, for sure. I had no idea, because I don't think any doctor I have seen has asked me if I would like to take the influenza shot, or maybe they asked it in such a nice way I declined. I'm not sure. But that's an eye opener. That is that's really, really an eye opener, because somehow influenza doesn't strike the same dread, in our hearts like something else would. I think there was some kind of a technical glitch with Dr. Sitesh. Moving on from influenza, Dr. Swaminathan, could we move to whooping cough? What is it, and how prevalent is it, or how much at risk is the common person for getting it? Yeah. Are they,
So pertussis, as we call it, is
Pertussis.
whooping cough. Well, all of us who are old enough, I guess, if you can remember, DPTK, teen TK zarur lagaiyega. If you remember
Yes.
then, well, it immediately dates you. But you know what? It did a lot for our country. But we need to understand that in those days, the DPT vaccine was a bit unpopular simply because it caused a lot of fever, and children used to be very cranky, and that made the parents very cranky as well. So we moved to a different formulation of pertussis, the acellular pertussis vaccine, which is a lot gentler, but unfortunately, it also is less long-standing. And therefore, we are starting to see pertussis in our older population. In fact, data from the US again, what they've shown is that when an adult comes in with 2 to 3 weeks of cough or more, 20% of the time it's pertussis. So adult pertussis is actually not that uncommon. And therefore, that is becoming an issue. So, and the problem is it's also pretty contagious across the family. So if one member of the household has pertussis, they can very quickly transmit it to other people in the workplace, other people in the family, and a single case in the right circumstance can infect up to 15 other people. And it can cause a lot of disruption in the workplace or at home, and the number of cases in adults is rising. That's why if you look at the current guideline, the recommendation is to use at least 1 dose of the DPT vaccine in adults, and the OBGY guidelines in US and many other countries has switched the tetanus toxoid vaccine to the DPT vaccine, simply because, again, it's more protection to the mother and therefore also to the baby and things like that. So obviously, pertussis is something that we are seeing a resurgence of today, and at least 1 dose of the vaccine in adulthood is a good idea.
That's who are the people who are more vulnerable to pertussis? I mean, is there a particular kind of demography which...
So the general group of people that we worry about are those with underlying chronic lung disease, because for them the respiratory reserve is already poor, and making them cough is probably going to be pretty scary. But again, see, it also depends on who you are. My transplant patients and things like that, I wouldn't want them to be coughing for 2 to 3 weeks, because you start going on a wild goose chase on really horrible things, whether it could be some fungal infection or black fungus, and it really creeps the diseases out of you. So if I have a very vulnerable person, I would definitely give it, because I want to have one less thing to worry about when the person falls sick. And for those people who have underlying respiratory conditions, I would definitely offer it, because their ability to stand up against this staccato of cough is more difficult, and they end up with more difficult problems.
That's great. And until such time, Dr. Roy joins us, Dr. Swaminathan,
Sure.
you're, I'm afraid, going to be in the...
Absolutely. Absolutely. Let's go.
Let's go. Let's
I'm
go.
game.
So, are there any contraindications to these vaccines? You know, do they have any side effects, or is there some of us who should not be going in for it, or most certainly should go in for it?
That's an important question. You know, in the last 100 years, there's been so many advancements in the technology of the vaccines. You know, parents complain to me all the time saying, oh my God, my baby is getting so many shots. But if you look at it, actually the vaccines are so pure now. What we were giving them was literally like engine oil about 50 years ago. Now we only have the active component. We don't have a whole amalgamation of all kinds of stuff being thrown into it. So what we call as an antigenic stimulation is very, very targeted, and we have much less of noise going in along with it. Therefore, vaccines today are much safer than they have ever been. And the reporting form for this in the Western world, at least, is incredibly robust. In the US, at least, they have what's called VAERS, in that anybody who's harmed by a vaccine is eligible for government compensation. And therefore, there is actually an incentive to report this. And based on that, we have excellent quality data as to what the actual number of problems is. And what we can say is that vaccines today are far safer than they have ever been. It is not to say that everything is perfect. Let me give you the example of, say, the rabies vaccine. You know, the rabies vaccine about 40 years ago was a really scary vaccine because we had all these neural vaccines which used to cause all kinds of medical problems. Today, the rabies vaccines are so safe. They are absolutely fantastic. There's really no reason not to use them practically in any age group. Having said that, there are a couple of things people need to know. We divide vaccines into live vaccines and either dead vaccines or component vaccines. Live vaccines obviously need to be handled a little carefully. You cannot give it to pregnant women. You cannot give it to those with medical problems where the immune system is bad, like transplant or blood cancer and things like that. But outside of that, really not major. Egg as a component of the vaccine, yes, some vaccines have egg as a component, but now we are having more and more vaccines which are coming out without using egg and things like that. So the acceptability of the vaccine is becoming better and better. And the people who are excluded from the vaccine campaign is shrinking on a daily basis. There are very few people who actually cannot take the vaccine. Most of the time, people avoid it due to fear, not because there is actually a medical reason.
Welcome back, Dr. Roy. Sorry, we lost you there for a bit. So Dr. Swaminathan was telling us about the whooping cough, but pertussis, is it?
Yes.
And you know, the vaccine for that. So we were asking him, you know, what was the number of people who actually got whooping cough? And he says the numbers are rising, especially amongst the older generation. So would you like to add something to that? Would you have an opinion on that, since you treat people of...
Sure. So you know, it's again a very interesting thing, because whooping cough vaccination, the diphtheria, tetanus, pertussis vaccine is given to every child. At least 5 doses are given by age 5. And they seem to be fairly well protected for around 10, 12, 15 years. Thereafter, the protection declines, and it's usually the youngsters in the family that bring the whooping cough into the home, and then it's the elderly, either the parents or the grandparents, who tend to catch it. And then it's treated as a cold that a person has, begins with some fever, sore throat, cough. We don't get the characteristic whoop. That's a very high-pitched sound that doesn't happen in adults, so it gets missed. And then they have a cough that goes on for 3 or 4 weeks, and there are many complications that can come out of it, and depending on the underlying health of the person. So in places like Sweden and other parts of the world, these cases have been studied very carefully, because the healthcare system allows them to track the cases. And the cases have literally gone up, in some places 50 to 90 times of what they were before. That's a very high increase. And in terms of the detected cases that are actually tested with a throat swab, like a nasopharyngeal swab to test for the infection, and the actual cases that are occurring, there's a huge difference because most people don't get tested. And we are seeing the same thing in India very likely, but we just don't have the test being done commonly. Like if you don't do a COVID test, you would never know you had COVID, right? It's the same thing with this. It's no different. And so we see the consequences of it with people coming in with 4 weeks, 5 weeks of cough and other problems due to it. And unless we begin a vaccination you can say program that takes care of people at least above the age of 40 or 50. 40 is ideal, above 50 is strongly recommended in these countries, and vaccinate them once in 10 years. We can really reduce again this is the healthcare burden, as Dr. Subramanian was mentioning.
Yes.
It's not people, these people are not going to die from whooping cough, but they'll have multiple visits to different doctors, possibly take a bunch of medications, undergo a lot of investigations for their cough, and end up with nothing once the disease kind of wanes off. But the suffering is immense, so quality of life goes down, and the cost on the patient and the healthcare system, the pressure on the healthcare system is immense. So I think that's really the key in this disease.
Okay. In whooping cough and in any others, as a matter of fact, because you did mention how, the cost of the vaccine, when you compare it to the medical costs and the other things, getting your tests done, buying the medicines, we have to do the math there and find out for ourselves about yes, we were talking about contraindications, about, who are the people who should take these vaccines and who should not take these vaccines. Dr. Swaminathan, you were saying something about live vaccines? Live vaccines? So what are can you give us a few examples of live vaccines?
Definitely. So when we look at the oral polio vaccine, that's a live vaccine. The injectable polio vaccine is a killed vaccine. So there are quite a few live vaccines we do use. So yellow fever vaccine, for example. Once in a while, I have my transplant recipients. I always ask my transplant recipients, are you ever planning to go to Australia or South America? No, doctor. 3 years later, they come back and say, I have to go for this conference in Brazil. And then they'll want an exemption saying they can't take the yellow fever vaccine. Oh, okay, so be it. The point is that once your immune system is bad or for some reason it cannot recover, you cannot take these live virus vaccines. Another example is the measles vaccine. So there are quite a few vaccines which are live virus. Fortunately, a lot of the vaccines we use today are either killed or component and things like that. But unfortunately, we still need a couple of live virus vaccines and we cannot do away with those.
But is there any, is it better to have a live vaccine than a not live one? Absolutely. Or the other way around?
No. It's not like that. See, the point is there are reasons why you cannot make a killed vaccine out of it. In that it only lends itself to what we call a live attenuated. It's not a wild virus which we're giving. We take the virus, we do something with it so that it becomes weaker, but it elicits the same response in the person so that the person becomes immune without suffering the ill effects of the vaccine. But the problem with that is if you have a person whose immune system is very bad, it can be tricky. Therefore, we still need live virus vaccines. They are still good options. But for many infections, we moved from those kind of vaccines to either killed or component vaccines.
Pankaja, I would just add one thing here, if I may. When we look at the oral polio vaccine, for example, in the oral polio vaccine also, there have been cases where people have acquired an infection from the oral polio virus, which is why many of the developed countries have moved away from giving any oral polio vaccine doses. We cannot do that because we have very large numbers to vaccinate here. But that very tiny risk of a live virus vaccine causing an infection always remains. There are, for example, there's a nasal flu vaccine, influenza vaccine, which again, we can't give to asthmatic patients because they can actually get an exacerbation of the asthma as they go about and are building their immunity to the vaccine. So I think the general theme is we try to move away from live virus or live attenuated is the right word, vaccinations, but they are going to be around for a reason. You're probably even going to see some for COVID come up in the future. So it's something that we have to realize has its place in the therapy, at least for the healthy people with a healthy immune system and no immune compromise.
I think that's important because it's not that the technology hasn't moved. It's just that these vaccines, some of these pathogens that we're worried about are incredibly tricky. And trying to avoid that vaccine is going to harm us a lot. Measles, the infectivity is so high. You need to have,
Exactly.
vaccination rates of 90 to 95%. Even 95% is just about it. So, trying to avoid these vaccines, saying it's live vaccine. I think we lost our host. She's just joining back. And
Yeah.
No,
yeah,
I'm
I
so
think she's
sorry.
joining.
The
okay.
power went
No,
off.
we're just having a nice conversation.
Okay, great.
Just having
That's
a nice
great.
conversation on live vaccines. No, I think Dr. Sitesh made some very beautiful comments on the live vaccine issue. In that, I think we really can't run away from it. In that, yes, the oral polio vaccine, like he said, rarely can cause trouble. But in a country of such a large size, for us to move to an injectable polio vaccine is very, very difficult. And remember, it's the pulse polio vaccination program across the world which was incredibly disruptive to the transmission of polio, which got us the control of it. You cannot do this with the oral polio vaccine. And for many of us who may not know that the pulse polio vaccine actually started in India in the 70s and was buried due to various reasons, and then had to come back to us from Brazil. So, point is that live vaccines have an important role to play, but yes, you need to be very careful. So, when as Dr. Sitesh pointed out about the nasal flu vaccine. So one of the issues that we tell people is that if you have pregnant women at home, none of you should be using the nasal flu vaccine because again, it can transmit. So we don't use the oral polio vaccine inside our campus simply because we have too many transplant recipients and vulnerable people like that. So nasal flu vaccine, oral polio, we do not use it inside the campus. Or nasal flu, never. Oral polio outside the campus, yes, but not inside the campus. So obviously you need to have mechanisms in place to increase safety.
So, coming to a subject which is closer to my heart, what are the vaccines you think are most urgently required for those who are over 50, and in my case, over 60? Because I can't remember the last vaccination I took. I mean, barring the COVID one.
So I think that I can go first, and I'm sure Dr. Subramanian can add later. As I said, the tetanus, diphtheria, attenuated pertussis vaccine, what's called the Tdap vaccine, is a very important one. The pneumonia vaccine, which I think currently above the age of 60 is given in India, but I believe there are many other age groups like people with asthma, COPD, immune compromise. All of them ideally should get it as adults also. And it does need to be given once in 5 years. The Tdap vaccine is once in 10 years. The influenza vaccination, the flu shot, which is required once a year because the virus, as was mentioned, mutates. And we have a new vaccine coming up for the influenza twice a year, what is called the Northern Hemisphere virus and the vaccine in the Southern Hemisphere, because as it gets winter in these two regions of the world is when the virus really spreads. And India, interestingly, has a monsoon season where also viruses are very high, and then a winter season also when the viruses are very high. I try to vaccinate my patient whenever I get a chance. I don't look at the season because I want to get them vaccinated. That's my goal. And then I try to get them on the right schedule, depending on whether they are in Western or Central India or Northern India, depending on what it is. So in terms of the zones, and then, as I lastly mentioned, the Zoster vaccine, the herpes zoster vaccine, or the shingles vaccine, as it is called in the West. I think these are four that I think come to my mind as being most prominent for adult vaccination. In the need-based group, the list can be much longer than this, like people who are immunocompromised, coming out of cancer, being on chemotherapy. But even for healthy adults, these four, I think, are key vaccinations.
And do you stagger them, or do you have them all at one go, or there is a schedule to be followed? In the sense, I can't go and say I want all these 4 vaccines on the same day, can I?
So like children, children are given 5 to 6 vaccines within one shot nowadays, Earlier, we used to have to literally hold the kid down and give 3 vaccines in one leg and 2 in the other. We don't do such stuff in adults because we have time technically on our hands. And what I generally do is I try to stagger my vaccines. Now, if you give 2 vaccines on the same day, generally you're okay giving it. It's when you give one, you have to wait at least 3 or 4 weeks for the first vaccine to do its job before you give the second one. So I tend to stagger and give my vaccines just to make the side effects less. Otherwise, if both your arms are paining, one has turned a little red, you've got a low-grade fever, you don't feel that great for a day or two, it's not a very nice feeling because that becomes a negative reinforcement for that human being to come back and take the next vaccine from me. So I tend to stagger, but generally the influenza and the pneumococcal vaccine, I generally give together because the patients with respiratory problems absolutely need it. And then the rest we can stagger depending on the age and the interest of the patient and how much they are convinced about taking it.
Dr. Swaminathan, would you like to add?
Oh, certainly. No, I think it's important, like you mentioned, that every opportunity to vaccinate should be utilized. And the most important...
Perfectly... sorry?
No, every opportunity to vaccinate should be utilized. And missed opportunities are a major issue because when you have the patient in front of you is the best time to vaccinate them. The only other vaccine I suppose I'd have to add is the COVID vaccine, which is the flavor of the year. So we have to talk about it, I guess. So, but yeah, but he's kind of covered everything else. And let me put it like this. See, it all depends on what kind of time frame you have and how much rapport you have. When I get my patients coming in for a organ transplant, I have no time. In which case, I don't have a choice. I have to get all of them in as quickly as possible. Certain things people should know. Generally, if you give a live virus vaccine, we don't give any other vaccines for the next 4 weeks because the live virus makes it difficult for the other vaccines to really take themselves up. You just don't react as well as that. So that's one thing people should be aware of. But again, it all depends. Okay, somebody's had the measles vaccine 3 days ago, and then now they get bitten by a dog. Am I going to say I'm not going to give the rabies vaccine? The answer is no. Yeah, I'm going to give the rabies vaccine. So it's all a question of what kind of pressure you're under, how much time you have, and how effectively you can do it. Obviously, you want to do it in the most sensible
circumstances
way.
And the need.
Absolutely. Personalize it to the patient.
I think the challenge is to have healthy adults to come and get themselves vaccinated. I mean, like you said, if there is, one of your patients who's already under certain stress and, immunocompromised is the word you use. But I think the thing is to get the healthy adults to start getting vaccinated so that they don't reach a stage where, things are critical. I guess that's what it is.
I say 2 things about that, Pankaja. One thing, I tell physicians to be more proactive, okay, and vaccinate themselves to protect themselves. They need it. And also their family members. So you start getting a wider ring of protection. And then whenever I get a patient in the clinic, I always offer vaccinations to the relatives or family members who are coming with them also. And I think that way the word gets out. But I think programs like this are so important to raise awareness. And I think the awareness, not just for the public, but also for the physicians and doctors, which I think is huge, because that's when we'll start getting the acceptance coming in. Because it'll, like in the US, you tell someone about a shingles vaccine and they don't have too many questions for you. They know what it is, why it is given. They know someone who has taken it in the past. They know what it does. Here, it would be like, what shingles? I don't know anything about it. So I think it's all about education, public and health professionals.
And as doctors, do you think it is also, we're all talking about changes in the environment, changes in the kind of food we eat, the kind of air we breathe, the water we drink, so on and so forth. Do you think that has had some kind of an impact on our our lifestyles are different, and therefore, we need to be a little bit more careful. Because honestly, that is a conversation point with the vaccines. And look at us, we are fine. But evidently, that's not the case anymore. So
apparently not. Apparently not. See, we are the diabetes capital of the world. So how can we be fine? How can we be fine? We are the diabetes capital of the world. We have more diabetes in India than anywhere else in the world. So how can we
Very
be fine?
true.
See, the point is that with medical advances, see, the life expectancy of a child born in the 1921 was about 20 to 21 years. Today it's 70 plus. So obviously we have done a lot. But the problem is also with longevity comes the burden of disease. And we now have the ability to sometimes keep people alive, sometimes against their wishes too. So what happens is we have a lot
Yes.
of people living with significant medical problems. You know, they have all kinds of
Quality of life.
rods and plates and implants and pacemakers and all kinds of stuff inside there. Not to mention that, you know, if you look at some of these, senior patients, they eat more tablets than they do food. So we have a lot of people living with a significant medical burden. And all of this, what people don't realize is that the medical conditions actually add more risk than just age. So as compared to a 65-year-old is absolutely healthy, a 50-year-old who's got asthma and is diabetic and a few other things is actually at much higher risk. So the problem is we not only have an aging population, we also have a population which is more unhealthy. And there is good data to show that non-communicable diseases are increasing. And as they increase, obviously, our concerns due to influenza and pneumococcus is only going to rise. And as Dr. Sitesh pointed out, shingles is going to be a big problem simply because we have an older population. And so, therefore, these things are only going to become more and more necessary. But I think there is this disconnect that we need to bridge between a rising need and a not so rising awareness.
Pankaja, I would want to add to what Dr. Subramanian has very clearly stated.
Yes.
What I feel is that when we look at our diet, our lifestyle, the kind of stressors that we are under today, when and this is a passion and love for me in my practice, in my work, in my lectures, in my research that I've done before, but I strongly believe that westernization of our diet and lifestyle is one of the biggest reasons why we are facing diabetes, heart disease, cancers. Allergic diseases have increased 200 to 300% in the last few decades in India. I think people need to wake up and realize that all the fast food and the junk food and the packaged food and everything else, we can't, to some extent, the air pollution and the water pollution, it's much bigger issue than you and I can handle or talk about. That's something that we have to, the administration wakes up, does its stuff, they're doing their job. They're trying to clean the air. They're trying to get to the goals that are being set around the world. But in our day-to-day life, I think our diet, lifestyle, and exercise, these are so critical because as an immunologist, people come and tell me, Dr. Roy, tell me what pills should I be taking so I don't get COVID-19? And my answer to them is get fresh air, get sunlight, get exercise. If you can do these three things and eat a good meal every day on time and get good sleep, you don't need any other pills above and beyond this. So I think that in this entire discussion, it's very interesting that you bring this up. I think that the awareness about why are we suffering more and more from these non-communicable diseases like diabetes, heart disease, requiring so many transplants, rods, implants, as Dr. Subramanian said, we really need to look at that just as critically as we need to recognize that these people need to be vaccinated to have a good quality of life and not have bad outcomes from things that can be very easily prevented.
That's right. And vaccinations are a necessity. They're not really a luxury or an option anymore. I think that point needs to be driven home, and they are a necessity at that point. There are some questions in the chat box if you would like to see that, and if there's any particular questions you would like to address in that.
Should healthcare workers be vaccinated more frequently? Oh, lovely question. The answer is yes. See, in the US, it's very easy. When I was there, if you did not want to take the influenza vaccine, you had to be wearing a mask fastidiously while you're on campus. If you do not wear the mask, your life is going to be very difficult for you. But in our country, unfortunately, the standards for all these things is very, very poor. I know there is a conversation going on about certain issues with regards to minimum standards of vaccination in the healthcare community. I can't talk more about that. So I think we need to have those kind of things sorted out, because as of right now, this is an area which is not being addressed. And my personal belief is this: if a physician starts using the vaccine for himself and his family, he's definitely going to start recommending it for the general public. So my efforts have always been geared towards getting the physician to use it for himself and his family, because that's the best form of ensuring acceptance. If they believe in it and they accept that it's adding value, they're going to start doing it. As of right now, that part itself is very, very poor.
I think so. I think so.
Based on the other questions that are there, Pankaja, very quickly request the panel to summarize the list of vaccines discussed today with the age of the person and the suggested group frequency. This is a very long answer. These are available on the internet. We have mentioned it. A person can go back and listen to it. We have mentioned quite a few of them. So that's one. The next is, Dr. Roy, is there a vaccine available to eradicate chronic asthma? No, asthma is not an infectious disease. Asthma is not a contagious disease. Asthma is an inflammatory disease which needs to be managed with the right kind of medications and controlled. Certainly, the triggers of asthma include infections, as we discussed, flu and pneumonia, the pneumococcal bug. And there are vaccines available to prevent those. So I think it goes a very long way in helping the person with chronic asthma not fall ill as often. Is the herpes zoster vaccine available in India? Soon to be. Good news. So it is going to be available. I believe there may be one already available, but I know that even from GSK, there's going to be one coming in the future. Recommendations for vaccines above the age of 50, these we have already mentioned in the chat, in the entire discussion. So I think you can just refer to the recording of that. I think that pretty much covers all of it.
That's right. That is right. And I think the thing is now to take it forward, like they said, should all health workers be vaccinated? I guess now, I think the corporate work area should step up and, encourage their employees to, I can't think of any other way to do it, because in our country, it's just the sheer numbers that are so overwhelming that to have any kind of a streamlined vaccination program, well, we have done it. So
it's very much possible. And like you said, not just the hospitals, which have done a fantastic job with all the healthcare professionals that they have, and with all the COVID-related vaccination that was given to so many doctors and paramedical health professionals, nurses. We know that it can be done, but I would also say the corporates have a very big responsibility, and many of them do approach us. We do health camps with them where we vaccinate their employees. And I think that it needs a uniform, as I would say, every individual, if they wake up, they ask their workplace and they ask their doctors about it, then it's more likely to become more widely accessible, available, and utilized.
That's right. Anything else you would like to add to it, Dr. Swaminathan, Dr. Roy?
I think, actually speaking, the non-healthcare sector is probably doing a better job at healthcare vaccination than the healthcare sector, because I've worked with the Occupational Health Society and we've published guidelines on that. And I was pleasantly surprised, let's just say that, when I noticed that so many corporates are actually vaccinating their work staff and making flu vaccine available. And somehow healthcare industry seems to be lagging in that effort. And this is where I would like to see more regulatory pressure coming in, which I think would be good for the whole system per se.
That's right. And I think the pandemic has, in a way, told us how it can be and how it can be managed and how it can, we did it. I know a lot of housing colonies which organized camps and things like that. So that way we are, I think after the Spanish flu, this came next. And most of us heard of the Spanish flu only now. So, we have short memories, but it's just been amazing talking to you. And I'm going to be going off and challenging my physician about a few things. He's a good friend and he's going to be surprised, I'm sure. Thank you very much, doctors, for your valuable time. It was really an eye-opening, what you shared with us was really, really eye-opening. And I think we all need to take a deep, hard look at where we are, especially the older, those of us who are older and who are still healthy and who can make decisions for ourselves. I think we should go out there and get ourselves vaccinated, if not for ourselves, at least for our, family members and potential caregivers. Thank you very much again. And we hope, we wish you a very happy, healthy life. And I hope you have taken all your shots too.
Yes, we have. And thank you very much. I think this has been a great program, and we appreciate you all having us as panelists, and we are happy to share our expertise and experience, and hope it gives people, whoever are tuning in and will see it in the future also on YouTube, a real perspective of what vaccination is, that it can be done safely. Unfortunately, vaccination took a very bad hit from some of the social media campaigns that ran against COVID vaccines. But having said all of that, vaccines are safe. They are around for a very long time. Done correctly in the right way at the right time for the right reason, they generally have very good outcomes. And that's kind of my message to people.
I agree. See, I think your safety should be in your hands. Preventing a problem is far better than going to the hospital and struggling. Day in and day out, we see problems. I was just talking about this at the beginning. The Institute of Medicine in the United States said 200 times as many adults died of vaccine-preventable diseases as children in the year 2000. 200 times. Okay. So that's a sobering statistic. And we don't even know what the numbers for India are. It's probably even worse. So I think we have lots of things we can do to keep ourselves safe. Let's invest in that. Just as we invest in wearing a helmet, a seatbelt, or a life insurance policy, this probably the payoff is even better. Numbers really back it up. So it just makes sense to ensure that we stay safe. Just like we wear a mask and do COVID appropriate behavior, this is also safety appropriate behavior.
Thank you so much. And I hope those of you who signed into the webinar are taking away some valuable information from Dr. Swaminathan and Dr. Roy. And go and get that jab and have a better quality life. Thank you so much. I know I'm heading out for sure. I'm picking up the phone and calling my doctor right away. So thank you so very much. Have a good day.
Thank you.
Bye-bye.
Pleasure.
Take care.
Take care.
Thank you. Thank you.